We are live.
Thank you. Good evening, friends, and welcome to the 4th episode of All India Postgraduate Teaching Program, which is a new initiative from ARC AIOS. This is a PG program with difference, covering the uncovered aspects of teaching program like case presentation, journal clubs, OSCEs, which you must have watched in last few episodes. In the first episode, we had a discussion on case discussion on glaucoma. Second episode, we had a journal club on glaucoma, and third was a didactic lecture on glaucoma diagnostics and surgicals. And this is the fourth episode now. So here we present our 4th episode of the series, in which we will learn how to read and interpret various charts or printouts of commonly used diagnostics in glaucoma, which are asked routinely in exams. And we have the best of the teachers in ophthalmology who will be guiding us, teaching us. It's my privilege to invite Professor Dr. Tanuj Dada sir, who is a head glaucoma services at RP Center of Ophthalmology, Delhi. Professor Kirti Singh ma'am, who is the director of GNEC, that is MAMC, Delhi. And George Putharan, who is a head glaucoma services at Arvind Eye Care Systems. Welcome, sir and ma'am. Also, our ARC member, Dr. Deepak Mishra from ARC Central. He is also a glaucoma consultant and a faculty of BHU, and he will be one amongst the discussant. We are lucky to have a great viewership. We have crossed 3,500 in all the episodes within 7 days. Now, I request today's program coordinator, Dr. Kasturi Bhattacharjee, who is a member ARC East, to carry forward the proceedings. Over to you, Dr. Kasturi ma'am.
Thank you, Dr. Prashant. Thank you for having all these interesting sessions for the PG. Like, I could see how tirelessly you have been working towards enhancing the training of students and empowering our next generation of the ophthalmologists. So it's a really great honor for us to have all the 3 luminaries in. Can you see my slides?
Yes, ma'am.
Yeah. So I'd like to give a brief introduction of all the 3 stalwarts. Professor George Putharan, he has graduated in medicine from the Government Medical College, Kottayam, and done his master's in ophthalmology from Aravind Eye Hospital. He joined Aravind in the year 1999 and currently heads the Department of Glaucoma. He's actively involved in teaching and training the residents, fellows, and practicing ophthalmologists. His main area of interest is in glaucoma drainage device in refractory glaucoma, and has been working with the Oro Lab in manufacturing and developing an affordable aqueous drainage implant, which has been extensively published on its safety and efficacy outcome. Welcome, Dr. George Putharan, to our session. So next we have none other than Dr. Tanuj Dada, who is currently the Professor of Ophthalmology and Head of Glaucoma Services at RP Center for Ophthalmic Science, AIIMS, New Delhi. He is the editor of All India Ophthalmological Society Guidelines for Diagnosis and Management of Primary Angle Closure Disease, Primary Open-Angle Glaucoma, and Glaucoma Surgery. He serves on the Board of Directors at the Asia Pacific Glaucoma Society. He has served on the International Council of Ophthalmology Committee for formulation of residency and glaucoma fellowship curricula. So we are so honored to have you with you today. Like you yourself had designed this residency program for the ICO. His current leadership position includes the Vice Chair of the Program Planning Committee for the World Glaucoma Congress, International Coordinator for Glaucoma Scientific Program at the APAO, and Chairman Scientific Committee of Asia Pacific Glaucoma Society. He has innovated 7 new techniques of glaucoma surgery and pioneered the research. And it's a great honor to have Professor Kirti Singh, who is the director at Guru Nanak Eye Center, the Maulana Azad Medical College, the prestigious Guru Nanak Eye Center. She is also heading the Department of Glaucoma Services. She has completed her post-graduation from All India Institute of Medical Science, recipient of numerous awards, including the Commonwealth Scholarship in 2000, the FRCs, and also the WHO Scholarship in 2010. She has authored multiple textbook chapters and also authored 3 textbooks on her own, having more than 55 publications, and has more than 350 lectures at state, national, and international conferences. So it's a great honor to have you with us, madam. So over to you, Professor George, for the first talk.
Thank you, Dr. Prashant and Dr. Kasturi, for that kind invitation and introduction. I hope I'm audible and my screen is visible.
Yes.
just to just keep my video off because I think there's some internet issues.
Okay.
And
No.
so coming, So coming to the imaging modalities in glaucoma, so I was asked to share the interpretation of GDX VCC and an HRT. Though physicians have moved away from GDX and HRT and are now mostly comfortable with the OCT, it's important for the postgraduates to have a basic knowledge of these two imaging modalities. So this is the glaucoma diagnosis VCC machine, and the scanning laser polarimetry is the imaging technology used in GDX, optimized for quantitative measurement of the nerve fiber layer for the detection and evaluation of glaucoma. It actually uses the birefringent properties of the retinal nerve fiber layer to quantify its thickness. The parallel arrangement of the microtubules within the retinal ganglion cell axons causes a quantifiable change in the polarization of light that passes through them. And this change is called retardation, and its numerical value is proportionate to the thickness of the nerve fiber layer. So PGs need to know certain terms here. Scanning laser polarimetry is one, birefringence is one, and retardation is the next. So the GDX VCC is the fourth commercial generation. The earlier ones were the nerve fiber analyzer, the NFA2, the GDX, and finally the GDX VCC. So the GDX device uses a diode laser wavelength of 780 nanometer for illumination and measurement of a 15 into 15 degree area of retina with an acquisition time of 0.7 seconds. So what is VCC? Apart from the retinal nerve fiber layer, the cornea and to a certain lesser degree, the lens and vitreous also have birefringent properties, and a compensator accounting for these components have been incorporated into the GDX. Before the development of the fourth generation of GDX VCC, the scanning laser polarimeter device used a fixed compensator. So this is the reflectance image, and this is a retardation image you get in a printout of the GDX. The reflectance image is generated from the light reflected directly from the surface of the retina and is displayed as the fundus image on the device and the printouts. So the retardation image is the map of retardation values and is converted into RNFL thickness based on a conversion factor. So this is a GDX VCC single exam printout. And this includes, it provides key information to correlate with your clinical ONH evaluation, automated perimetry to aid in making a diagnosis. And this includes the fundus image, the thickness map, the deviation map, the TSNIT graph, and there is a TSNIT parameter table also incorporated. We will try to go through each. So the fundus image is useful for image quality. Is the image focused? Is it adequately illuminated? And is the ellipse centered on the optic nerve head? The thickness map displays the retinal nerve fiber layer and the thickness values using a high resolution color map, where the thicker regions are colored in yellow and red, and thinner regions are colored in blue and green. So these are the thicker regions, the superior and inferior RNFL, and the rest of the thinner areas are in blue and green. So the deviation map reveals the location and severity of the retinal nerve fiber layer loss displayed with a color-coded superpixels. So this is the deviation map. This is the normal, and this is highly suggestive of glaucoma. So this is based on the probability level. The deviation map compares each individual's entire 3D retinal nerve fiber layer scan to the normative database. And the deviation map reveals the location and magnitude of the retinal nerve fiber defects in the 3D representation. And these defects are color coded based on the probability of normality as compared to the database, with red indicating the most severe loss. So just for the postgraduates to understand, the correlation between the thickness map, the visual fields, and the deviation map is shown. For it, this is the normal. This may be a pre-perimetric retinal nerve fiber loss. This is probably a moderate glaucoma, and this is a severe glaucoma. Notice that for the moderate and advanced glaucoma example, the retinal nerve fiber layer defects corresponds with the visual field defect. And in the pre-perimetric example, there is a wedge-shaped retinal nerve fiber layer defect here. There's a wedge-shaped here. See the thickness that has been reduced, and see the deviation map. So this is an indication to look more closely, either by your clinical ONH evaluation or look closely at the fundus photo to see whether this is correlating to either make a diagnosis of or exclude glaucoma. Coming to the TSNIT graph. So this is also extremely important. The scan starts at the temporal aspects, goes superior, nasal, inferior, and then finishes at the temporal. So you will hear a lot of TSNIT probably in the next OCT presentation also. So the normal values are within the shaded area, and abnormal values fall below the shaded area. So what you need to know, there's a typical double hump pattern where at the superior and the inferior retinal nerve fiber layer, the thickness is maximum. And coming to the parameters, these are based on the TS. You should understand that these parameters are based on the TSNIT graph. And this is a summary based on the calculation circle. And the values outside, it's extreme. You need not remember any of these values. What you need to know that values outside normal are color coded based on the probability of normality compared to the normative database. So green numbers are normal. Green numbers are normal. That is probability within the 95% normal range. You have the dark blue, which is borderline, where the probability is outside the 95% normal range. The light blue, which is abnormal, probability is outside the 98% normal range. Yellow values are again abnormal, probability outside 99% normal range. And red is again abnormal, probability outside the 99.5% normal range. So this is how the scan is done. Starts temporal, proceeds superiorly. So this is the TSNIT. And so you have the TSNIT average, which is the average RNFL thickness. You will have a superior average. These are important in the printout. So superior average is RNFL thickness in the superior 120 degree of the calculation circle, and the inferior average is the average RNFL thickness in the inferior 120 degree of the calculation circle. So again, there is something called a TSNIT standard deviation in the printout. So this is actually captures the modulation, that is the difference between the peak to trough difference of the double hump pattern. So if it is normal, this is a high value. The difference between the peak to trough in a normal is a high value. And once the peak to trough values, once it starts going down, this is again highly suggestive of. So this is one of the parameters included in the TSNIT parameter. Inter-eye symmetry is also shown. Values, because in normal, usually there is good symmetry, and in glaucoma, probably there must be usually poor symmetry. So values near 1 represent good symmetry, values near 0 represent poor symmetry. So this is a very important part of the TSNIT parameter, the nerve fiber indicator. The nerve fiber indicator is a parameter that measures both focal and diffuse retinal nerve fiber layer loss. And NFI is calculated using an advanced form of a neural network trained to discriminate normal from glaucoma. And probably NFI is the most sensitive parameter in the GDX VCC printout for discriminating normal from glaucoma. And the output ranges from 1 to 100. Values falling below 30 are classified as normal. Values between 31 and 50 borderline. And values above 50 are classified as abnormal. So even though it is just the RNFL thickness that is being evaluated, this format of comparing each scan to the normative database actually used to allow easy and accurate interpretation in one examination. This was the advantage of the GDX VCC. And postgraduates should also know that apart from the single symmetry analysis, there was also an advanced serial analysis which was available with the GDX VCC, where up to 4 serial scans could be compared to assess progression. So coming to the second part, which is the Heidelberg retina tomograph, and I will probably be concentrating more on the HRT2, which the physicians, the glaucoma surgeons were comfortable using some time back. And by the time the HRT3 came, surgeons actually shifted more towards the OCT. So if the postgraduates get a printout of an HRT, it's highly likely that it's going to be an HRT2 printout. So we talked about scanning laser polarimetry for GDX. The confocal scanning laser ophthalmoscopy is the imaging technique used in Heidelberg retinal tomography. And it helps in acquisition and quantitative analysis of the three-dimensional images of the posterior segment. So it describes the topography of the retina and the optic nerve head. And the HRT uses a 670 nanometer diode laser, sharply focused, and it captures a series of 32 sequential two-dimensional scans. And the initial scans are focused anterior to the retina, and the last scans are posterior to the bottom of the optic cup. So the number of scanned planes ranges from 16 to 64, depending on the optic disc depth. And a three-dimensional image is acquired as 32 consecutive and equidistant optical section images, and topography images are computed from the acquired three-dimensional image. So this is the topographic ONH map you see in the HRT. The red area marks the cup, and the green and the blue area marks the neuroretinal rim. One important thing postgraduates should understand is the operator is required to trace the ONH margin, and based on this, and this is a contour line, the operator traces the optic nerve head margin, and the HRT operation software actually automatically in HRT2 defines the reference plane. So this plane is located 50 micrometer posterior to the mean surface height, posterior micrometer posterior to the mean surface height along a 6-degree arcade, a 6-degree arc at the inferotemporal region of the contour line. So these are the contour lines, the optic nerve head margins, and this reference plane is then used as a topographic cutoff. Structures below the plane are defined as the optic cup, and the structures above the plane as the neuroretinal rim. And as I mentioned before, the two black lines perpendicular to the height profile denotes the borders of the disc as defined by the contour line. So this is another important thing postgraduates should know. HRT uses MRA, which stands for Moorfield's regression analysis, for classifying different sectors of the optic nerve. So you should know that a green tick marks a normal. A green tick mark denotes a normal area, and a red cross an abnormal area. Again, this is HRT scan of a normal subject. This is the upper left image, shows the topographical ONH map. Again, we saw that the red area marks the cup, and the green and the blue areas mark the neuroretinal rim. This upper right image is the reflectance image, just like what you had in the GDX VCC. And the reflectance image is shown with the tracing of the optic disc in green outline. So this is the tracing of the optic nerve head in green outline, and the optic cup. It's not very clear, but it's in red outline here, in a red outline. And all of the ONH sectors here, if you see, all of the ONH sectors are marked with green check mark, signifying that they are within normal limits based on Moorfield's regression analysis. And at the bottom of the figure, this is a graph which depicts the surface height along the contour line. So this is the reference plane. And again, you can note that the normal double hump appearance with higher thickness in the superior and also in the inferior regions. Again, this reference, this green line, this is the surface height. This should never follow below the reference line. So the mean contour height graph is something, again, which comes out in a HRT printout. It graphically displays height of the retinal tissue along the contour line, and it provides a calculation of thickness of the nerve fiber layer. So the reference line is red, and the height contour line is green in the HRT printout. And the green contour line should not go below the reference plane. If it does, then the contour line is likely not in proper position. So mean height contour line is drawn again clockwise for the right eye and counterclockwise for the left eye. Starts at temporal region, moves superior, nasal, and inferior to finish at the temporal location. So this is what I was mentioning in GDX VCC also: temporal, superior, nasal, and inferior. So as I was mentioning, contour may be diminished locally. That is, it can be diminished locally, or it can even fall at the red line, but it can never go below the reference plane. It may be diminished locally, which is the focal damage, or diffusely with an area of contour line, or the entire line falling close to the reference plane. So for the postgraduates to understand, the Moorfield regression analysis defines areas normal, borderline, outside normal limits based on 95, 99, 99% and 99.9% confidence intervals. So in HRT printout, you will, for the Moorfield regression analysis, you will get a printout like this. So you will have a cup area which is shown by red, and you have the rim area shown by green. And these are the 6 sectors which are scanned. If you look, there is a predicted, there is a low 95%, there is a low 99%, and there is a low 99.9%, which is lines which are drawn here. You should know that for a predicted value, 50% of the normative data database have a percentage share of rim area that is greater than this limit. If the percentage share of the measured rim area in a sector is greater than or equal to the lower 95% confidence interval limit, the respective sector is classified as being within normal limits. I'll go back and show you. So this is the predicted value. See the low 95%. So here the rim area falls above the low 95%. Here also this line, this is the low 95%. The rim area falls above.
Hello, sir. We cannot hear you, sir. Hello.
I think there is some network issue with sir.
So I think, sir, can you hear us?
His connection is stuck now.
Okay.
Oh.
So we have Kirti ma'am, we have Tanush Rana. In the meantime, let's see if we have any questions from any of the. There is one question by one of the residents who wants to know which value of NFI signifies early glaucoma in GDX. So, do you have any specific value of NFI which that this value denotes early glaucoma? Is there something like this, sir?
Oh, actually, you have to see the complete clinical picture of the patient, because you can have a lot of false positive with these imaging technologies. So it's not good to have cutoff values for making diagnosis. You have to see the topography of the optic nerve, the retinal nerve fiber layer defect, and then match it with the abnormality on the GDX. So using a summary parameter like NFI to make diagnosis is not, and I'll explain it later on in my presentation.
So there's one more question. They want to know HRT is more for monitoring the progression of glaucoma, or is it for more of diagnosis?
HRT is not much useful for diagnosis. It is good for long-term monitoring of glaucoma patients. But now with coming of OCT, it's not being used much.
Thank you, sir. I think Dr. George, you have joined. Would you like to finish your slides?
No, ma'am, his network is lost. Host, can you stop sharing so that we can start the next talk by Tanu sir? Is it possible? Yeah.
Should I start?
Yes, sir. We can see
Yes,
your
sir.
So good evening, everybody, and thank you to Dr. Prashant and the team at ARC. And thank you, Dr. Kasturi, for your very gracious introduction. So today I'll be covering key messages on how to use OCT for glaucoma patients. And this requires a lot of detail and rehearsal, and I'll be giving a link at the end. We just released an AIOS module on OCT, so residents can go through it in detail. So basically, why you are using all these machines? Because you have to answer this critical question: does the patient have glaucoma? For making a diagnosis of glaucoma, you need to document a retinal nerve fiber layer defect and focal thinning of the neuroretinal rim before visual field defects become apparent. And that is the utility of using these machines such as GDX or HRT or OCT for glaucoma diagnosis. In glaucoma training, you must learn to identify the retinal nerve fiber layer defects when you take a fundus photograph. So any glaucoma patient, gold standard is to take color and red-free fundus photograph and learn to identify the retinal nerve fiber layer defects, these wedge-shaped dark patterns which can be seen emanating from the disc margin. So the first important message is, like you have seen in conferences, neuroradiology, the MRI or the CT scan is read in great detail. Before interpreting the OCT, you sit with the optic disc photograph and learn to see the retinal nerve fiber layer as well as each aspect of the optic disc. Like in this patient, there is a superior retinal nerve fiber layer defect, and use the OCT to complement your clinical knowledge, what you have seen on the optic disc. When you have the OCT, there is a very good initial tool in the OCT called the multicolor image. So before you go to the actual OCT interpretation, you get this pseudo multicolor image. And this is very useful because it can pick up the retinal nerve fiber layer defects, especially there is a green reflectance and a blue reflectance where these RNFL defects become very prominent. So before you interpret the OCT further, from this image, you can actually make out whether there is a structural defect in the retinal nerve fiber layer. This is very important before you interpret the OCT. As far as we are concerned, the main advantage of using the OCT is to rule out glaucoma, and especially patients presenting with an enlarged cup disc ratio, which looks very suspicious. That is where you use the OCT to rule out glaucoma if it is absolutely within normal limits. Now, many times you have patient presenting with suspicious disc and there is a abnormal OCT, but you are not sure of the diagnosis. In that situation, it is always better not to make a diagnosis, just label the patient as a glaucoma suspect and then follow up the patient over time. Now, the major problem in all these imaging technologies is that there is a huge variability in the optic nerve head structure and the number of axons in the optic nerve head. So it is very difficult to differentiate normal from glaucoma at one point in time. So the best technique is to follow up the patient over time and compare the patient against his own baseline database. And if you see a change over time, that is the best way to diagnose glaucoma, and do not make a diagnosis at a single snapshot of the OCT. The next important question is which parameter to evaluate on the OCT. So you have a number of parameters now available. In generally, we are evaluating the retinal nerve fiber layer, the ganglion cell complex in the macula, and the neuroretinal rim. Newer technologies like OCT, angiography, lamina curvature imaging have become available. For practical use, the first three parameters are the ones that you should learn how to interpret. So basically, the ganglion cell has three components. It has got the ganglion cell body, and then the axon, and the inner plexiform layer, and the retinal nerve fiber layer. So together, this structure comprises the ganglion cell complex. And that is why it is very important to image this, because this may be one of the earliest signs of glaucoma damage in addition to the retinal nerve fiber layer that we are measuring. An important concept to understand is that when you look at the OCT, first you must learn to identify the retinal nerve fiber layer defects. And why this is more important, because clinically you can correlate the retinal nerve fiber layer defect with the defect on the OCT. But clinically, you can't compare or correlate the OCT ganglion cell defects with the fundus photograph. That is why we rely more on the retinal nerve fiber layer parameters, because visibly you can correlate this with the defect occurring on the OCT. When is it essential to use the ganglion cell parameters over and above retinal nerve fiber layer? When you have artifacts or congenital disc anomalies, when there is an advanced case where the retinal nerve fiber layer has already reached the floor effect, that means there is no further loss which can occur, to differentiate myopia from glaucoma. And especially in patients with normal pressure glaucoma, where the ganglion cell loss may be preceding the retinal nerve fiber layer loss. If patient has got a macular pathology, then there is no point in evaluating the ganglion cell complex. And the limitation is that you can't correlate the GCC on the OCT with the clinical examination. The third important thing is that whenever you interpret the OCT, try to correlate the three important structures. So you should document the retinal nerve fiber layer change, see for corresponding defects in the macular area and the neuroretinal rim. So if all three structures show corresponding damage, that is a clear-cut indication that the patient has got glaucoma. In recent OCTs, you have this wide field scan available. So here, the advantage is you can image both the retinal nerve fiber layer as well as the ganglion cell complex in one scan. And that is very advantageous. Here you can see there is an inferior RNFL defect visible on the OCT. And this is correlating with loss in the central ganglion cell complex. So this is entire one congruous region, the ganglion cell loss in the macula corresponding with the inferior retinal nerve fiber layer defect. So this is a very good correlation where you have RNFL damage associated with the ganglion cell complex damage. And here you can see the loss of the retinal nerve fiber layer. Whenever this black line of the patient falls into the red region, that denotes that it is 99% abnormal. Less than 1% of the normal population will have this sort of retinal nerve fiber layer thickness. Now, coming to the interpretation, it is very important that you capture the fundus image and see whether the scan is well centered. And before you interpret the OCT, always check the boundary of the retinal nerve fiber layer. This is a critical error that often takes place, whether the OCT has identified the margins of the retinal nerve fiber layer correctly. Then you see any defect in the neuroretinal rim, corresponding defects in the retinal nerve fiber layer. And then you look for the retinal asymmetry, whether there is an asymmetry between the superior macula or the inferior macula, and see if there is loss in the ganglion cell. So now you can see there is an inferior RNFL defect visible here. There is a loss of the inferior temporal neuroretinal rim, corresponding defect in the inferior retinal nerve fiber layer, and a corresponding defect in the ganglion cell complex in the inferior macula. So this is the clear-cut diagnosis of glaucoma with all structures correlating to your diagnosis of glaucoma. Another case you can see here, left eye RNFL defect, neuroretinal rim damage correlating with RNFL damage. And here you can see the loss of the ganglion cell. This is a retinal thickness asymmetry map like you have the glaucoma hemifield test. So inferior loss compared to superior normal. And you can see this is the normal ganglion cell, and the blue area shows loss of ganglion cell. So inferior ganglion cell complex has been lost. So all are correlating, depicting that there is inferior retinal nerve fiber layer damage. So the best way to confirm glaucoma in a suspected patient is to repeat the scanning of the patient every 4 to 6 months. And if you have progression of a defect or a widening of the defect with the same quality scan score, that confirms the diagnosis of glaucoma instead of relying on a single one scan diagnosis. The next important thing is where to look for the glaucoma defects on the OCT. And here I just want to make a point, what is known as the macular vulnerability zone. So this is the part of the macula, especially in the inferior temporal region, which is most vulnerable. And most of the early defects you will get in the inferior temporal part of the macula. So any OCT scan, first look for inferior temporal defects in the macula and the RNFL, and then look for superior temporal defects. So these are two regions where you will get the maximum defects on the OCT. And these defects will never cross the horizontal meridian. Okay. So this inferior temporal and superior temporal is the area where you will get early glaucoma defects. When you take the scan, the patient must be well centered, avoid air current because dry eye can lead to a poor quality image. And most important thing is, if you're not getting a good scan, dilate the patient, checking for a shallow AC before, and see what is the signal strength. Any patient who has got lenticular opacification or a posterior capsule opacification will get a poor score. So this for the patient referred to me, you can see diagnosed as glaucoma, and patient already on treatment with xylatan, and you can see OCT showing inferior RNFL defect. But when cataract surgery was done, you can see 53 is the RNFL thickness. Post cataract surgery, 53 has gone to 113. So cataract was causing a false underestimation of the retinal nerve fiber layer thickness, and post cataract surgery, this has been taken care of. When you follow up these patients over time, you must see what is the signal strength. This is a patient who has been diagnosed as progression. You can see that the scan is following a downward trajectory and all the sectors are labeled as progression. But when you see the signal strength, the initial scan shows 7 on 10 and the recent scan shows 2 on 10. So this is loss of signal strength due to cataract formation that is leading to a false progression, which is a very important thing. The RNFL dropping from 105 micron to 85 micron, but this is due to poor signal strength dropping from 7 on 10 to 2 on 10. So unless you do cataract surgery and establish a new baseline, this is a false progression due to development of cataract. Very important artifact on the OCT. The major issue with the OCT is that you have very high percentage of artifacts. Nearly 50% of scans may have artifacts due to overestimation or underestimation. The main artifact is called the boundary misinterpretation artifact. And before you interpret the OCT scans, you must go and see the OCT image. Now here you can see there is an underestimation of the retinal nerve fiber layer, not due to glaucoma, due to a bad scan. So the scan has picked up wrongly the retinal nerve fiber layer boundary. Now the operator has to correct this and your glaucoma will become normal. So always check the boundary of the retinal nerve fiber layer, whether it is correctly put by the machine. If not, you have to manually correct it before you interpret the OCT scan. If you have vitreous floaters, they can cause underestimation of the retinal nerve fiber layer. Like you can see this large floater on the optic disc. If you have epiretinal membranes, they can lead to overestimation of the retinal nerve fiber layer. And this is a patient with congenital disc anomalies. In this situation, RNFL can be totally erroneous. Concentrate on the ganglion cell complex because you can get RNFL abnormalities due to congenital disc anomaly. So this is a word of caution before you interpret these scans. So before you interpret the OCT, always check the signal strength appropriate to the machine. Check the boundary of the retinal nerve fiber layer. Rule out partial vitreomacular traction epiretinal membrane. And remember, OCT does not have the congenital anomaly in the database, so don't interpret the RNFL in such cases. You should always see the total thickness map of the OCT because this is independent of the normative database of the machine, and then compare right versus left and superior versus inferior. This is the total deviation map. This is independent of the normative database. So the thicker colors, red and yellow, denote normal RNFL. And here you can see there is a blue streak denoting a RNFL defect inferiorly. This is matching with the deviation map, which is comparing to normal population. You can see there is an inferior RNFL defect. And this is matching with the topography. There is an inferior RNFL defect here. So the thickness map reveals the initial RNFL defect. And these are the average values, which you don't have to memorize. Just see whether they are from the normal population, how they deviate from normal population. Concentrate on the boundary of the RNFL and then see if there is any abnormality in the total retinal thickness map. This is the earliest sign you will pick up of glaucoma. Some patients have got a physiological bifid RNFL. You can see two splits. This is normal. This can be a normal variation. Don't think of this as glaucoma. And just introducing what is green disease. Green disease is when the OCT is normal, but patient has glaucoma. So this is a patient where you can see OCT quadrant sectors as completely normal. But actually, if you see, the patient has got a superior retinal nerve fiber layer defect. So although the OCT sectors are coming as green, the patient has got a RNFL defect, which is not captured on the OCT summary parameters. Another important question is that can we interchange OCT machines? When you follow up the patient, the answer is no. Different machines have got different algorithm and they vary extremely in the thickness that they are capturing. So you can't on follow-up use different OCT machine, use the same manufacturer for follow-up. And of course, you can change the model number and upgrade the machines, but don't change the basic technology or the different companies for the OCT. And finally, should we use RNFL or the ganglion cell complex for imaging? The answer is you should use both because you can have RNFL progression before ganglion cell progression. And in some cases, you can have ganglion cell progression before retinal nerve fiber layer. So it is good to image both the retinal nerve fiber layer as well as the ganglion cell complex for imaging and follow up these patients over time and also see if there is any defect which is occurring in the neuroretinal rim, which is matching the progression in your visual field. It is very important to do imaging serially to follow up these patients over time. If you get progression confirmed across 2 visits in the inferotemporal or temporotemporal region, that is a consideration for treatment, taking other factors such as IOP, risk factors, family history. Advanced glaucoma, basically not much use of OCT, better to use the visual fields. Although some people advocate you can use JCC. So finally, this is a patient 45-year-old surgeon referred to me already on Travatan, large cup disc ratio diagnosed as glaucoma, HRT showing abnormal sectors, but RNFL absolutely normal. So that is why ruling out glaucoma is very important. Another patient referred, and you can see here this was misdiagnosed, that patient is normal, but when the visual fields are nearly normal, when we did the OCT, you can see inferior RNFL defect, and then you go back and see, you can pick up a RNFL defect. So the important thing is always go back and see the area where the OCT is depicting the defect for a clinically visible RNFL. That is how you will learn how to identify the RNFL defect. So go back and re-examine the area which is flagged by the OCT. And finally, you should correlate the structural changes in the RNFL as the glaucoma advances, superior RNFL defect, very nicely visible here, with the ganglion cell complex, the RNFL, the boundary of the neuroretinal rim, and then correlate the structure. So superior notching and inferior visual field defect, that is a proper correlation for diagnosing glaucoma. So to summarize, use OCT to confirm clinical examination. It can help you to rule out glaucoma, especially useful for glaucoma suspects, early glaucoma, useful in patients who cannot perform perimetry. It provides a good objective baseline to monitor change, and you should use combined information from the RNFL, ganglion cell complex, and the neuroretinal rim. Never treat the patient based on just an abnormal OCT. Always check the signal strength at each visit. Learn to read the RNFL boundary and the artifacts. Look for lenticular changes that can decrease signal strength. So OCT is not essential, but it can help you to diagnose and follow up your patients if you know when and how to use it, and if you know when it is not reliable. Use it to complement your clinical examination. And this is the AIOS OCT module. You can go in detail and learn more about how to interpret OCT in different conditions. Thank you very much. Jai Hind.
Thank you, sir, for the excellent topic. Like, it was so nice. We have also learned so much from you. Sir, there are basically 3 questions for you. Number 1 is, are there any contraindications for OCT? And if so, what are the contraindications?
No, I think the OCT is a non-contact investigation. So I think clinically there is no contraindication as such. But if patient has got very advanced glaucoma, then the OCT gives very little information. Those patients, no point using it. There you rely on the visual fields.
So there's one more question. What are the different types of OCTs?
See, currently the initial OCTs were time domain OCTs, but currently we are using the spectral domain OCT, and now you also have enhanced depth imaging OCTs, swept source. So basically the frequency keeps on increasing and you get higher resolution scans. So currently spectral domain is an adequate technology which is being used by most centers across the world.
Then there's one more question by Dr. Revati. In case having CDR of 0.7 clinically, but RNFL thickness is normal, GCL thickness is normal, but borderline or low thickness in OCT, how to proceed with such patients?
So as I told you, whenever you are in doubt, label the patient as glaucoma suspect and redo the OCT after 4 to 6 months across 3 visits. If it is static, no change, you are just following the patient. If there is a deterioration over time, loss of RNFL thickness, appearance of RNFL defects clinically, then you can diagnose the patient of glaucoma. So at this point, the clinical situation is just labeling patient as a glaucoma suspect. No treatment.
Thank you, sir. Dr. Deepak, would you like to add or ask, sir?
No, and it's already excellent talk, and what you said, it's true that every time when we listen, sir, we got something new, and it's truly the merit of the sir's talk that everyone will sit at a point to listen it. Meanwhile, Dr. George sir left with only 2-3 slides. I request George sir to kindly finish his talk. Then we will ask whatever the another questions are there with the Tanu sir.
Okay, sure.
Please.
Dr. Deepak, my slides are visible.
Yes,
Yes.
yes.
Yes, sir.
Yeah, sorry for this technical glitch. I'll just very quickly finish off this. So I just wanted to show that if this rim area goes below the 99.9% confidence interval, then you get this outside normal limit stick in the HRT. So this is the HRT printout. This is a normal, and this is the abnormal printout. And there are a lot of stereometric analysis here. And luckily, all these have the normal range also shown against this early, moderate, and advanced disease. So things we look at are the rim area, the rim volume, and the mean RNFL thickness. Unfortunately, with technology, HRT3 came up, and the Moorfields regression analysis was totally taken out of the picture, and you get a glaucoma probability score in HRT3. So postgraduates should know this. Unlike Moorfield regression analysis, which was used in HRT2, the glaucoma probability score utilizes using advanced artificial intelligence. The software employs a new 3D shape analysis, combining measures of the optic nerve head and the peripapillary retina into a sophisticated model. So this is the HRT3 printout. You don't have the Moorfield regression analysis, and it is simplified. The stereometric analysis has also been simplified into 5 parameters. These are the rim steepness, the cup size, the cup depth, and the horizontal and the vertical retinal nerve fiber layer curvature. So the glaucoma probability score uses a geometric model to describe the shape of the optic disc and the peripapillary retina based. So you just get a single probability score here. It's within normal limits, borderline, or outside normal limits. Again, the same GPS. Actually, this was initially very attractive because this glaucoma probability score, given its ease of use, there was no operator dependence because it was they didn't have to mark the contour of the optic nerve head. There was no reference plane. The software directly came out with this glaucoma probability score. So this was the HRT2. This is the HRT3. And as Professor Tanuj Dada was repeatedly saying, imaging just complements our intraocular pressure gonioscopy, which is very important, the Humphrey visual fields, and most importantly, the clinical ONH evaluation. Postgraduates should know that they will miss a lot of glaucoma if they don't do a gonioscopy. All glaucoma suspects have to undergo an undilated gonioscopy, and it is worth the effort to know how to identify. Professor Dada was also showing a lot of retinal nerve fiber layer defects. It is really worth the effort to identify retinal nerve fiber layer defects in a fundus photograph, and also by your clinical ONH evaluation. You can even look for progression with progressive documentation of your stereo photographs. Thank you very much.
Thank you, sir, very much. I think some very interesting questions are coming up. I think I'll request Kirti Madam to finish her talk, and then we can open up those questions to all the 3 faculties. Madam, Kirti Madam.
Yeah, am I audible?
Yes, ma'am.
Okay. So visible?
Yes, ma'am.
All right. Thank you, Dr. Prashant and the ARC team. It's always lovely to talk to residents, and here goes. So I'm talking about, the previous 2 speakers have talked about imaging and the structural damage. I'm going to talk about functional damage, and OCT and GDX or HRT have been with us for last 30-40 years. However, fields have been there since the time of Jerome and Trekvar, and Humphrey field, or why I talk about Humphreys, because it's the one which we commonly have. Most of us all over India, octopus few people have, but octopus initially was the initial one. So in the exams, always you may be invariably given a Humphrey perimeter printout to interpret. So remember, Humphrey perimeter mimics the Goldman viewing conditions. The default target size is 3, which is equivalent to 5/4 of Goldman. Brightest target is 10,000 apostles. However, the 10,000 apostles is very difficult to place on the field. That is why you convert it into decibel. So 10,000 apostles, the brightest light is 0 decibel, that is the least sensitivity, and normally 40 decibel is a very good sensitivity, which means 1 apostle. So this, why I'm highlighting this, these are the common questions we ask while interpret the perimeter, that why is it apostle and decibel, and more the decibels, which means more sensitive is the retina, that is, it is able to perceive the lesser apostles, and macula has the maximal sensitivity. The test strategies of standard automated perimetry, sometimes called as the standard achromatic perimetry or STRAP, is these drop-down menu will come when you take on the Humphrey field. Central 24-2, 24-2C is the new one I'll be just covering. Central 10-2, the peripheral macula and nasal step, I will not be covering too much, and neither I will be covering too much of a total pure threshold, because that's not done anymore. Mostly it has been supplanted by CETA. So these are the test strategies. And again, a question asked is, why do we do only till 30 degrees? Why is it 30-2 and 24-2? 30 because the maximal nerve fibers which are affected in glaucoma or the papillomacular bundle is in 30 degrees. That is why 30 degrees central fields are done. And 30-2 has 76 points and 24-2 has 54 points. And in advanced glaucoma, you do 10-2 with 10 degree, which is central 10 degrees or 68 points. And macular program is 5 degrees or 16 points. So I'll be covering each of these perimetry, each of these printouts. CETA, we very often come to CETA. What is CETA? I'll just come to it. You have three issues in CETA: CETA faster, CETA standard, and CETA fast. Invariably, you would have a printout with CETA standard or fast. Faster is not very commonly used. However, if the patient is uncooperative or if the patient is really very good follow-up, you can do CETA faster. So full threshold strategy is now being supplanted by CETA. Initially, full threshold came, then fastpack came, and then CETA came in 1997, and then CETA fast came, and now you have CETA faster. CETA fast, CETA standard would have lesser time, obviously, and CETA 7 minutes per eye, and CETA faster is 2 minutes per eye. What is CETA? A question again asked. Swedish interactive threshold algorithm. It's an algorithm, and how do you differentiate it? Some of the old centers you'll get a threshold test printout. In that, you would have the fixation losses in fractions and short-term fluctuation and corrected pattern standard deviation. Whereas the moment the CETA strategy or algorithm is used, you'll have fixation loss in fractions and false positive and false negative as percentages. I'll show you these individually to tell you how it is. Other algorithms is ZEST and TOP. Now, age is a very important criteria, and CETA will compute the value depending on the age-corrected normal population. So let's come one by one to this. 30-2 printout, 76 points, density is 6 degrees. Default size is stimulus 3, okay? And this is, as I said, CETA standard is a common strategy, okay? The other one is the, 24-2. It is centrally only 24 degrees, but nasally it extends till 30 degrees. So if you're asked, why is this printout shaped like this, but called 24-2? Because it incorporates the nasal step. It has 54 points, again 6 degrees apart, and the peripheral rim of the 30-2 has been removed. So the advantage of 24-2 strategy is that it gives you most information at a faster pace and can be superimposed on a 30-2. The other field, which would be very commonly given to you, would be 10 degrees or 10-2. It has 68 points. So it is very densely packed. The density is 2 degrees. Again, size 3 or size 5 can be used, and size 5, if they're used, it means the sensitivity is low. So always look at this point of stimulus, what size it is. What is a disadvantage in 10-2? The central 1 degree radius is from the fixation is still untested. Moment you have a 10-2, you will not have a GHT analysis and visual field index is not calculated. You'll only have MD and PSD. Okay. Macular threshold is very, very rarely given to you and very, very rarely done. It is done usually in advanced glaucoma. It is the central 16 points of the 10-2, the central 16 points of the 10-2. The points are 2 degrees apart. And why do you have these brackets? Again, a question asked, why do you have these brackets? Because these points are tested twice. Okay. Again, CETA strategies are not available in this. Now you come to the aspects which are important for interpretation. I don't want to show our residents just these slides and make you mug them up or ask for a printout. Ma'am, can we have that? I want you to understand it. So fixation target, I'm going to give you all the drop-down menus. When you have the fixation target, you can have the central fixation target, or you can have the small diamond or the large diamond. Invariably, it is central fixation target. And invariably, your foveal threshold would be off. Please remember, if you are, obviously when you get the field, you can't determine that, but when you are doing or ordering a field, try to get the foveal threshold on. So this is the central target. To understand, this is the central target with the yellow dot. This is the inferior small diamond and large diamond. A question often asked is, when do you shift the central fixation target? The answer is when you have macular pathologies which will cause persistent fixation losses. So if you have a macular pathology, the patient of this type will not be able to see from here, but maybe by the inferior large diamond, they may have some fixation and you can do a field. Then you must also know about the fixation monitoring. Fixation monitoring is invariably done by the blind spot. And the next question asked is, what is the blind spot method of fixation monitoring? And that's called as the heel-Croco method. The J is silent, heel-Croco method. I'll come to it afterwards. Now, this is the guidelines of Hodap, Parrish, Anderson criteria of which fields are abnormal. Please remember, as Dr. Tanuj also was telling you, never rely on one imaging, never rely on one field. You have to have the minimal abnormality criteria of Hodap, Parrish, Anderson on 2 consecutive visual fields. And in 30-2, if the field is 30-2, it deletes the edge point. For 24-2, the edge points are considered because anyway, the peripheral rim has been deleted except the nasal step. And it is 3 contiguous non-edge points in a location typical for glaucoma depressed on pattern deviation plot with a p-value of less than 5 and one of which has p-value of 1%. CPST and PST, I'll come to this again and again. These are the most important tests for glaucoma and they should be depressed to less than 5% and GHT is outside normal limits. Reiterating, reproducible change and remember the learning curve. Now we come to the sequence. You understood the basic foundations of interpretation. Now we come to the sequence. I've made a color coding to tell you how the interpretation happens. So sequence is 1 is the patient data. In the patient data, you have to first see the date of birth. Please remember the patient ages, the eye ages. So if you fill this up wrongly, then the machine has an age matched normative database and it will read wrongly and give a false interpretation. So visual field you should be dependent on the actual age of the patient. Second is the pupil. And if the pupil diameter is less, okay, there'll be edge scotomas. Now this is a 24- field with seems to have a constriction, seems to have a biarcuate defect. But if you look at the pupil, this is just 2 millimeters. Normal pupil should be 3 to 4. If it is small, dilated, and the new machines after gaze initialization, they will measure the pupil themselves. And remember, perimetry is a test done in a semi-dark room. So pupil will be little dilated. Okay. Second thing you must rule out is the refractive error. See, it was mentioned here, the refractive error. Why? Because refractive blur will increase the threshold and the trial lens has to be placed properly and centered. And in the perimetry, you have to correlate the foveal threshold with the visual acuity. Now, this patient has a 6/9 vision and a foveal threshold of 31, which is little less. It should be around 40. So try to see whether it is is there any media opacity or is there any refractive error uncorrected. But this is uncorrected, or you haven't placed the trial lens properly. So this is again in the interpretation important of the patient data. Foveal threshold is calculated very early in the test, even before initialization. And this threshold is marked in the center, and then the initialization process starts and the blind spot is marked. Okay. Second aspect is the reliability indices. As we talked about the gaze and blind spot, I talked about, and the fixation target is central, fixation losses, and false positive and false negative. Let's come to them one by one. Fixation losses, we talked about the blind spot monitoring or the Heel-Krakow method. 5% stimuli are flashed on the blind spot. If eye has moved from fixation, this is the blind spot stimuli 1 to 5, and this is the blind spot size. So many stimuli can fit in the blind spot, but if the blind spot moves a little, if the patient moves more, the blind spot obviously moves. And if the eye has moved from fixation, patient will see it. So the important thing to understand is that the blind spot charting is done after initialization. Therefore, the machine will formulate the trackwards hill of vision based on that and the foveal threshold. This is the blind spot. Often the examiner will hide which eye it is. So you will look at the blind spot, and in the raw data, you will have this triangle. So this blind spot is always marked by a triangle. Second thing it can be tracked is with the gaze tracker. So reliability was the false positives and the fixation losses. Fixation losses were checked by the Heel-Krakow method or by the gaze tracker and the video monitor. Gaze tracker is given at the bottom of the field. Lot of movements means bad. Some blinks would be there, and the blinks would be shown by downward deflection. Upward deflections are fixation losses. So this is a relatively okay gaze tracker, but this one is showing a lot of fixation losses. So this type of field you want to redo. Okay. And in the new machines, the video monitor is showing a very nicely a green cross or a red one. And if the patient is centered, it will have a green star. So the perimetrist can see very well. Now the fixation losses are mentioned as a ratio. What is unreliable? You'll always be asked, is this field reliable or not reliable? More than 20% is unreliable, and they're usually marked as XX. Pseudo loss is there if there's a head tilt. If the nasal field of the other eye has not been included, or there is faulty initialization. So this is fixation losses. As I said, double cross would be there. Therefore, you will interpret this field that this is an unreliable field. Yes, it is showing some changes from the blind spot, but I would like to do this field again because this is not a reliable field. Second part is the false positive. Okay, these are trigger happy patients who are highly false positive. Machine would give small auditory stimulus without light. These are called as catch trials on full threshold. But CETA has an algorithm with anticipated button pressing, and 15%, more than 15% would be unreliable. How to prevent this false trial is demonstrate, do the proper initialization, and warn the patient that some light will be too dim. This now is also showing you fixation losses, double cross more than 20%, false positive 11%, and false negative 53%. So this is an unreliable field, and this may be also glaucomatous field, but you would mark it as unreliable. Can you visualize these second aspects as in the brackets, the other numbers, decibels given in the raw scale? Can you see that, Dr. Kasturi? Is it visible?
Yes, ma'am. We can
So
see.
if some centers you come for any exam, they may show you this field. Okay. Now see, these double crosses are there. In this, it is percentage. So this is the newer machines. These are the older machines, and this is the threshold values. very few people would have this threshold because this threshold will take a longer time. And as I told you, it would have a short-term fluctuation and a corrected pattern standard deviation. The new ones would have a visual field index and a MD and a pattern standard. So if you have picked up this, I can guarantee you'll have a D Viva. Okay, that if you have picked up that this is the threshold field, then we come to false negative. False negative, what does it mean? That a patient had responded to a supra-threshold stimulus 9 decibels more than the threshold in an area previously in the same test, and now he is not responding. So this means that the eye has gone into inattention, patient is fatigued or has become unresponsive, or the visual field is depressed, or the patient is malignant, or it is glaucomatous damage. So there are a lot of odds and false negatives, okay? And how much is called as poor reliability is 15% for CETA. So as you can see now, this is a new field because it has fixation losses as a fraction, positive and negatives as percentage, and here it is showing you that this is a false negative excessive false negative, okay? And can you understand, can you see this pattern? Remember when I told you in the initial period, the machine does the foveal threshold first, and then it checks the initialization in these quadrants. After that, let's say patient snoozed off or went to sleep, and the machine has tested these areas and they are coming as dark. This is only when the patient has fatigue. And this is typically called as clover leaf pattern because it looks like a 4-leaf clover. Okay, so again, this is a very favorite question. I'm repeating this: older visual field, which will have the X's, new one, which will have the percentage. Okay, so, and if you can see here, a lot of blinking responses are there, lots of false positives are there. So again, this field by both the fixation losses and by the gaze tracking is not reliable. All right. So we've talked about the reliability. Second thing is the learning curve. What do we mean by learning curve? Supposing you are shown these two fields together of the same patient. First of all, you will check whether the same patient is there. Then you will see really, okay, this one had an unreliable field, but same field has suddenly become more reliable. This means that the patient has learned or understood how to perform the field correctly. And this learning curve is one main reason why all of us tell you that first, don't rely on one field, have minimal 2 reproducible fields. What is reproducible? It has the similar pattern and both have to be reliable. Again, learning curve, same patient over some time. Now this you would label it as a sectorial defect. Here there is not much defect. So again, a learning curve just based on the reliability aspects. Third thing in interpretation is the grayscale. Our eyes go to it naturally because it is pictorial. It is a shaded topographic map. However, it is not compared to normals. It is good to explain to the patient that you have kalamoti or glaucoma, and otherwise it is of not much use for analysis. Okay. Also showing you again an older field which has the, so this is the threshold field, okay, which is not very often done now. Next, the more important ones is the total deviation and the pattern deviation, numerical and the plots. Okay, what is the total deviation numerical plot and the total deviation probability plot? What it does is from the normative age matched data bank, for that point, it subtracts the mean decibels and the difference is printed. So this is difference. So if the number is 0, that means patient is normal, that is no difference from normal. A negative sign means that this patient is lesser than normal. Uniform loss means that the difference in maximum and minimum will be normal, and it can be seen in cataract or media opacities. Then you have the total deviation probability plot. Here, the numerical data is converted to probability value and is given the p-value where the black squares are given. P less than 0.5 is black squares. Again, total deviation may be reduced in media opacities like cataract, corneal opacities, and pupil miosis, which used to be seen in our time when patients were on pilocarpine. Then we come to call the pattern deviation numerical plot. it estimates the normal theoretical hill of vision. How does it do that? You have a lot of scattered pattern, and the 7th best point is selected, and the 3 points next to the optic disc and the peripheral points, they're called as edge points. They are ignored, and the 7th point is made into 0. Okay, and therefore the general height of hill of vision is lifted. Therefore, what it does is it negates the global reductions. Now we come to the most important thing in glaucoma is the pattern deviation numerical plot and pattern deviation probability plot. The contour of the trackwards hill of vision is unaltered, but the height is artifactually pulled up. It highlights the deep scotomas, and it's most important for pathological defects. And this basically unmasks the patterns from generalized depressions. And if you remember your Kodab-Parrish-Anderson criteria, what was it? 3 contiguous non-edge points in a location on pattern deviation plot. So the criteria use this, CETA also uses this one to say what is abnormal field and what is abnormal field. However, there's some caveats to it. In advanced glaucoma, where total deviation is so much, but this is absolutely normal or not detected because the pattern deviation is not there. So in those situations, you cannot rely on field. Second, as I told you, in macular pathologies, again, you can't rely on that. Now, this is a patient like Dr. Tanuj was showing you. This patient also had a lot of defects in the center. It wasn't actually matching the glaucoma defects. And this patient, when he was subjected to cataract surgery, see the change. So this patient was pre and post phacoemulsification. So pattern deviation has a caveat. You look at where the pattern is coming up. Okay. Briefly, in next 3-4 slides, I'll be showing you some classical patterns. Visual field in glaucoma is a story of patterns. This is a superior arcuate defect. Okay, right? This is an enlarged blind spot. Both are pretty much seen in glaucoma. This can be seen in other conditions too. This is a biarcuate defect. It evolves from the blind spot. Please remember, triangle. This is the triangle, which was the blind spot. And it evolves from the blind spot. This is also known as the Jerem scotoma. This is a superior arcuate scotoma. Yes? No, it is not, because it is not coming from the, not contiguous from the blind spot. So this is the patient with the brow ptosis, and once you repeat the visual field, you find that this is lost. This is gone. Okay. So when you elevate, you have to tape up this eye to get the brow ptosis to go. So you must ensure that it is coming from the blind spot. So when if this field is given to you, because it is not coming from the blind spot, you will say, I would like to repeat the field, or I would like to clinically evaluate the patient in totality. Again, a very common field given to you is 10-2 macular split, classical temporal island. Last, we come to the global indices. This is the glaucoma hemifield test outside normal limits, visual field index, MD, and PSD. Mean deviation is the average field loss, and it is deviation from normal weight scale with the variance at that location. The points closer to fixation affect the MD more. It has almost been replaced by visual field index, which has come up. And this is a percentage of visual field correction corrected for age. Range is from 1 to 100%. Central points are given more weightage than peripheral ones. Why? Because ganglion cells are there in the center. And you have the rate and event based analysis, where the change of parameters over time is done with VFI. And VFI, if it has a negative slope over time, it indicates progression. Then we just highlight on pattern standard deviation. It is the index of roughness of loss. It is high in glaucoma localized field defect. I always give the example of Himalayas and Vindhyachal mountains. Himalayas are young mountains, a lot of pattern, a lot of high peaks and troughs. Okay, so in glaucoma, what is PSD? It's going to, if you are having a Vindhyachal mountain actually, because the whole retina is depressed. Now, what does pattern standard deviation do is converts the Vindhyachal mountain into Himalayas by pulling up the peaks which were little up, but not too much depressed, and making it artifactually more. So it artifactually increases the hill of vision to enhance the pattern in the field loss. So this is called as this is how the pattern standard deviation is done. And in VFI, MD and PST are the global indices. Glaucoma hemifield test has these 5 messages which we all talk about, but please remember glaucoma hemifield test will not be able to pick up the temporal wedge. Raw threshold data is not very often talked about. Only when you have advanced glaucoma, as I showed you in the caveats, when you have no pattern deviation, then you would go and look at the raw data. Last, about the 24-2, if you have reached this level, then that means the examiner is very happy with you. They are showing you 24-2C protocol. This is combining 24-2 with select points in the central 10 degrees. Why? Because macula has 30% of retinal ganglion cells which are damaged in glaucoma. 24-2 test was only including 4 points in this area. 24-2C has extra points. This is the CETA standard for 24-2C, 24-2, and this is 24-2C. Can you see this pattern? This pattern would be done in a CETA faster, and you can see that the 24-2 can't pick up the visual field effects, but 24-2C CETA faster has picked up. So 24-2 is coming up very recently as the new modality. However, it still has to pass the test of time. And for people who want to read this practical guide to interpret visual fields by Reddy and effective perimetry by Heel is one of the good resource materials. My takeaway slide, we are facing floods all over India. Be safe. And how can we contribute? All of you residents, please contribute by minimizing, optimizing plastic use, because our excessive use of Earth's resources and our excessive disregard of Earth is causing all this climate warming and climate pollution and floods or fires. Please, let's reduce or optimize plastic use. Thank you.
Thank you, madam, for the great talk. Now we have few questions, and can I ask all of you to be please in the video mode? So there is a very interesting question from Dr. Gargi. She is a resident at Sri Shankardev Netralaya. She wants to know when to start doing fields in childhood glaucoma patients.
Okay, Dr. Gargi. In number one, depends on how old the child is, whether they are able to sit on the perimeter. I told you, because the machine is relying on, if you understood the fundamental points I was making, fixation, blind spot is very important for the field, for the machine to chart. If they can't find the foveal threshold or the blind spot, the machine goes blind. It cannot do much. It just click, 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 but it will not give much. Second, if the child is less than 18 years, CETA cannot work. The database, normative database is not there. It will generate a field, but it cannot give you the statistical indices. So the pattern deviation probability plots and things won't come. The raw data would come. So these are the problems in childhood glaucoma less than 18 years. However, having said that, if you really want to follow up childhood glaucoma by fields and the child is able to fixate and sit on the perimeter, go by raw data, disc evaluation would give you a better clue for documenting progression in childhood glaucoma than fields, because of these above reasons I've told you.
There is a question to Dr. Tanuj from Dr. Charu. Like how to monitor and document glaucoma progression in nystagmus patient. Can we do perimetry for such patients?
No, I think the quality of the image will be slightly difficult to capture on the OCT if the patient is mobile. But I think if you can dilate and you get a good signal strength, then it is okay. But if there is a gross nystagmus, I think it will be tough to get a good quality scan on the OCT.
So there's one more question to you. Many a times, glaucoma patients develop retinal diseases like ARMD, BRVO. How to monitor and manage such patients?
See, regarding OCT, if you have macular pathology, then one parameter goes out. That is ganglion cell complex. So in that situation, you have to monitor the neuroretinal rim and the retinal nerve fiber layer and see your clinical picture, because now you cannot monitor the patient on the macular parameters. So that is the difference. A second thing is you have to be very sure of the boundary of the RNFL, whether it is accurate or whether it is impacted by macular pathologies. But when you have partial PVD or ERM or age-related changes, it pulls up the retinal nerve fiber layer, causes false overestimation. So I think macular pathologies, you must learn first to interpret and see the RNFL boundary, whether it is actually captured or is there an artifact, and then only you can interpret the OCT further.
Thank you, sir. Dr. Mohan Lal wants to know, sometimes we get GCC thinning, but the disc remains normal. How do we proceed in such patients?
So actually, that is the most common error. We get false positive on the GCC because the segmentation of, because actually they capture the retinal nerve fiber layer thickness and then OCT segments out the ganglion cell layer. So first thing is always check the total retinal thickness. If the total retinal thickness is normal and you are getting GCC loss, that means it's an artifact. Second thing is, if you have isolated GCC loss, there is no visual field defect. Clinically, fundus is normal. There is no RNFL defect. Don't start treatment. Follow up the patient over time. You can repeat OCT after 4 to 6 months, 3 serial OCTs. If you see that defect has disappeared, it is artifact. If defect is not progressing, nothing to be done. If the defect starts progressing and you get associated RNFL defect or thinning in neuroretinal rim, then only you can start the patient on therapy. So this is very spurious sign. Don't start therapy. If you just get GCC thinning, we get a lot of cases which are false positive.
Thank you, sir. There's a question from Dr. Partha. Question to Dr. George, please. That is there any advantage of HRT over OCT? Dr. George, are you there?
Yeah, I'm there. I don't think so. I think the glaucoma physicians and surgeons have moved away from using HRT for OCT RNFL thickness, and I think it's totally dependent on OCT nowadays. I hope Professor Kirti Singh and Professor Tanuj Tada would agree to that.
Yeah, totally agree.
Yes. HRT came up with more field regression, MRA, then GDX came up, but then went, and then OCT is here to stay.
So if it's just that if you're investing on an imaging modality, invest in an OCT.
Madam, there's a question to you. Can we perform 24-2C on the same Humphrey machine that is being used currently, or do we need some advanced model?
There's a software which the new Humphrey, the Humphrey machines, the HFA3 with the 841, they put the software, but it can be incorporated in that. And as I showed you the picture, you have 24-2 and then 24-2C both in the same patient, same machine. Yes.
Ma'am, there is question to Kirti ma'am. What are the advantages and disadvantages of Humphrey on the octopus? One of the resident asked it. Maybe it was his.
Okay, so octopus, again, I have no personal experience. This is all theoretical. But octopus was the first machine to come in, and they have something very similar, the ZEST protocol and the top protocol like CETA and Humphrey. Advantages or disadvantages, that also has, you can tell progression from a different algorithms, and this one also you can tell. But because Humphrey is more widely used, again, no financial interest, but that's more widely available. So I really don't see any advantage. And for the PG point of view, for this ARC program, wherever you go, exam centers, you will invariably be given Humphrey and not octopus because of the sheer non-presence of octopus all over.
Okay, thank you. One question to Tanu sir. Sir, what is the ideal signal strength to have a good OCT picture? Out of 10, what value should be the ideal for a good OCT scan?
See, 10 is for the Zeiss platform. Cirrus OCT, ideally score should be 7 or above, ideally. But every platform, Spectralis or OptoView, has its own signal strength, signal to noise ratio. So it is not 10, it is different for every machine. So you have to see the manufacturer and see what is the cutoff for each special machine. Okay.
Sir, there is one more question to you. In some printout, it is written fovea off. What does that mean?
That is for Dr. Kirti, madam.
I'm your.
Yeah. So I think that's for me. So yeah, I did show the residents that they picked up the fovea. I especially said when you have the drop-down box, try to make the fovea on. Again, I'm repeating, foveal threshold is calibrated very early on by the new algorithms. Okay, because reason, you have to understand the reason, only then you'll remember. Because the trackwards halo of vision will be based on that, will be computed on that. Now, why should the fovea be on? Because you need to have the foveal threshold to correlate actually. Why is the fovea off? Because often when we are seeing glaucoma patients, the foveal threshold is pretty low, and that takes more time and the patient gets fatigued. So just to unmask the pattern, the perimetrist may push the fovea off and the machine then runs in a faster way. Otherwise, wherever possible, try to have the fovea on.
Madam, one more question to you. When do we ask for 10-2 fields and macular threshold test? Should we do it on the first visit, or if this change is not severely affected?
I think I'll have to re-speak the entire perimetry because I said very clearly 24-2 or 30-2 and 24-2 are the threshold tests. You will first do that only for the glaucoma suspects or for glaucoma diagnosis or for confirmation of glaucoma. You will only come down to central 10 degrees, which is macular 10-2 or macular threshold when the 24-2 or 30-2 is so severely damaged that the pattern can't come up and the patient has advanced glaucoma. In that situation, you would want to have more points in the central, tightly packed, 2 degrees packed in the center to really highlight whether how much is the macular split is there or not. Because the moment the macular split is there, your surgical prognosis, your surgical interventions and the precautions will change. Okay. So no, you will not do a macular 10-. Macular threshold anyways done less commonly. The common one is 10-2. No, you will not do a 10-2 first time. You will first time only do a 24-2 or a 30-2 depending. And you will only do a 10-2 if the patient is unable to fixate at all and requires a size 5 stimulus. Even then he can't fixate. Then you will come down to macular threshold. And in advanced glaucoma, once the already 10-2 is affected, then for follow-up also you will do a 10-2. So one 10-2 you'll do for diagnosis in advanced glaucoma and follow-up after you treat it, because 24-2 or 30-2 will not give you further information.
Thank you, madam. I think with this, we come to the end of today's session. Thank you, Dr. Tanuj sir, Dr. George sir, and madam. It was really a great learning experience from all of us. And on behalf of Dr. Prashant Bhavankale, the chairman ARC and the team ARC, we are extremely thankful to each one of you and also to the residents for being with us for these 1.5 hours. Thank you, everybody, and good night.
Thank you.
So thanks from the whole GC of the IOS, sir.
Thank you.
Thank you.
Thank you, sir. Thank you.
And I'd also like to make an announcement. Next week on Thursday, we have 2 cases on glaucoma, which will be presented by 2 residents, one from Jipmer and one from AIMS Bhopal. So I request all
cornea cases.
Yeah, there'll be in cornea. I request all of you to please join us and please open out all your queries so that the panelists will be able to solve and answer to all your queries. Thank you, everybody, and good night.
Thank you.